Hi, everyone. I'm Dr. Pramil Chirayath, Chief Medical Officer here in the United States. I'm excited to welcome you all today as we explore another important and timely topic in medical education. Today, we'll be diving into systemic lupus erythematosus, SLE, diagnosis and approach. We'll cover real-world clinical scenarios, diagnostic strategies, and treatment planning, helping you build strong foundations in managing this complex disease. If you find this helpful, don't forget to like, follow, and subscribe to the ResearchMD channel on YouTube for more educational and interesting topics uploaded every day. Pathophysiology of SLE. SLE is an autoimmune disease where the body's immune system mistakenly attacks its own healthy tissues. This attack specifically targets the nucleus inside cells, leading to the formation of immune complexes that deposit in various organs throughout the body. These immune complexes trigger chronic inflammation and tissue damage in critical organs, including the skin, joints, kidneys, heart, and brain. The resulting systemic inflammation causes the diverse array of symptoms seen in lupus patients. Think of SLE as the body's defense system going rogue, damaging critical systems instead of protecting them, creating a cascade of inflammatory responses that can affect virtually any organ system. Autoimmunity. Immune system attacks healthy tissues. Nuclear targeting antibodies target cell nuclei, immune complex formation complexes, deposit in tissues. Tissue damage, inflammation causes organ dysfunction. Diagnostic criteria for SLE. Diagnosing SLE requires a comprehensive approach combining clinical symptoms and laboratory findings. The disease presents with a constellation of signs that can vary significantly between patients, making diagnosis challenging. Clinical manifestations range from the characteristic malar butterfly rash to serious organ involvement. Laboratory tests, particularly autoantibody profiles, help confirm the diagnosis and assess disease activity. A systematic evaluation of both clinical and laboratory criteria is essential for accurate diagnosis and appropriate management of this complex condition. Clinical symptoms: malar butterfly, rash across cheeks, discoid rash, thick scaly patches, photosensitivity, sun sensitivity, oral ulcers, arthritis, joint pain, swelling, multi-organ involvement. Laboratory findings: positive ANA, sensitive but not specific, positive anti-dsDNA antibodies, positive anti-Smith antibodies, low complement proteins, C3, C4, proteinuria or hematuria. Clinical scenario 1, classic presentation. A 28-year-old woman presents with the classic triad of lupus symptoms: fatigue, joint pains, and a photosensitive rash. Her laboratory findings strongly support the diagnosis with positive ANA, low complement levels, and elevated anti-dsDNA antibodies. This represents a textbook case of systemic lupus erythematosus. The facial butterfly rash that worsens with sun exposure is pathognomonic for SLE. Joint pain, arthralgia, is typically one of the earliest manifestations of the disease. This case highlights the importance of considering SLE in young women presenting with this combination of symptoms and laboratory findings, as early diagnosis leads to better outcomes. Patient presentation: 28-year-old woman, fatigue and joint pains, photosensitive rash. Laboratory findings: ANA positive, low complement levels, elevated anti-dsDNA antibodies. Diagnosis: systemic lupus erythematosus, SLE. Clinical scenario 2, lupus nephritis. A 35-year-old man with established lupus presents with concerning signs of kidney involvement, hematuria, and hypertension. His laboratory findings show elevated creatinine indicating kidney stress and low C3 complement suggesting active disease. When SLE patients develop kidney problems, lupus nephritis should be suspected, a serious complication that requires prompt evaluation. The next appropriate step is a renal biopsy to determine the specific class of nephritis. Different classes of lupus nephritis require different therapeutic approaches, with some necessitating aggressive immunosuppression, while others may be managed more conservatively. This case emphasizes the importance of kidney monitoring in SLE patients. Kidney involvement, hematuria, hypertension, elevated creatinine renal biopsy determines nephritis class, targeted treatment based on nephritis classification. Clinical scenario 3, multisystem involvement. A 25-year-old woman presents with a complex constellation of symptoms including fatigue, joint pains, classic malar rash, and hematologic abnormalities affecting all blood cell lines. Her laboratory findings show positive autoantibodies, low complement, and evidence of kidney involvement. This case demonstrates the multi-system nature of SLE, affecting joints, skin, blood cells, and kidneys simultaneously. The presence of proteinuria and hematuria indicates kidney involvement, which requires further evaluation. A kidney biopsy is the appropriate next step to classify the severity of lupus nephritis and guide treatment decisions regarding immunosuppressive therapy. This case highlights the importance of comprehensive evaluation in SLE patients with multi-organ involvement. Kidney biopsy, next diagnostic step, hematologic abnormalities, anemia, leukopenia, thrombocytopenia, skin manifestations, classic malar rash, joint symptoms, fatigue and joint pains. Clinical scenario 4, active lupus nephritis. A woman with established SLE develops alarming signs of active kidney disease, new onset hematuria, rising creatinine levels, and urinalysis showing red blood cell casts with heavy proteinuria. These findings point to a clear diagnosis of active lupus nephritis. Red blood cell casts are particularly significant as they represent a strong marker for glomerular inflammation, a hallmark of serious lupus kidney disease. Their presence indicates active inflammation within the kidney's filtering units. This scenario emphasizes the importance of regular monitoring of kidney function in SLE patients and prompt recognition of nephritis flares. Early intervention with appropriate immunosuppressive therapy is crucial to prevent permanent kidney damage. RBC casts, strong marker of glomerular inflammation. Creatinine indicates declining kidney function. Proteinuria, heavy protein loss in urine. Clinical scenario 5, antiphospholipid syndrome. A 28-year-old woman presents with a complex clinical picture including fever, oral ulcers, Raynaud's phenomenon, and joint pain. Her laboratory findings reveal positive lupus anticoagulant, raising concern for a serious complication of SLE. This constellation of symptoms, particularly with positive lupus anticoagulant, should prompt suspicion for thromboembolism due to antiphospholipid syndrome, a condition where patients paradoxically develop blood clots despite having anticoagulant antibodies. Clinicians must remain vigilant for potentially life-threatening complications like strokes, deep vein thrombosis, and pulmonary embolism in these patients. This case highlights the importance of recognizing this dangerous complication of SLE. Lupus anticoagulant paradoxically increases clotting risk, thromboembolism, blood clots in vessels, serious complications, strokes, DVT, pulmonary embolism. That concludes today's session on systemic lupus erythematosus diagnosis and approach. If you found this helpful, don't forget to like, comment, and subscribe to the Research MD channel for more high-yield educational videos uploaded every day. Drop your questions or share your experiences in the comments. Let's keep learning together. Until next time, keep learning, stay curious, and stay safe. God bless all.